We have our next speaker, Stephan Kemp, who is going to be speaking on his gray zone project. So for those of you who are not familiar with the gray zone project, so the gray zone project emerged out of the observation that there were lots of variants of uncertain significance coming out of newborn screening. And Stephan Kemp was well positioned to analyze this. He's been running basically out of his cellar, his back cellar, this wonderful website that every clinician around the world uses to reference ABCD1 variant analysis. So Stephan has taken on this project to help provide some clarity to what he has been calling the gray zone, which is this area between the clear black and white of disease-causing and benign variants. And Stephan is here to give us an update on this project. It's been a wonderful, long-running project here, and we're excited to hear the update. Stephan, thank you.
Thank you, Keith. Good morning, everybody. It's a really pleasure to be here again and to see so many people I know for a long time, and many of you who haven't met yet before. So I also want to collect some pins, so I want to share and talk with you. And if you have any questions on this project, please ask, because I've realized that it's technically it's fairly simple, but it may not be that clear immediately. So some of the slides that are in here were there last year, and I always say that the power is in repetition. You don't, I mean, if you hear something for the first time, it may not stick. It may raise questions. So I'll try to explain the Gray Zone project. And actually, there's the Gray Zone project 1.0, and there's also a 2.0 now. Yeah, so these are my disclosures. And I want to start off with a really good news, because experimentally and scientifically, the Gray Zone project is not sexy at all. So to get funding in a competitive landscape of research projects, this is almost impossible, because scientifically it's rather boring, because it's doing a lot of diagnostics. So we're really, really happy that we just received a new grant from the Virginia Tubman Foundation. And for that, I would like to thank Kelly and Alison Adler, because without Kelly and Alison, this would not have been possible. So we received another $100,000. And this will all go to families who want to participate in the Gray Zone project. And even though often it's said that it's a research project, it is not a research project. It is trying to get insight into a situation where it's very unclear. And I talk a lot without showing any data. So, but this is the background of the Gray Zone project, and I will show that. So this is really great, because now we can continue and we can offer free diagnostic testing for, well, many families. Because for $100,000 we can do, well, more than 1,000 assays, I think. Okay, so when we talk about newborn screening, we basically are talking about population screening. And population screening is really important, because it offers significant advantages to individuals. Because it enables timely follow-up and intervention, and it can save lives. However, and this is from Sir Murray Gray from the UK, and this is really true. What is here? So, because in addition to the benefits, all screening programs do harm. Some also do good. And of these, some do more good than harm at reasonable cost. And what it means is that in population screening there are benefits and there are challenges and harms. And so next to the benefits, which are obvious, there's early identification of individuals at risk. It allows for timely follow-up and intervention. and thereby it improves long-term health outcomes, and it reduces morbidity and mortality for target diseases. However, on the other hand, there are harms and challenges. Because many, not only ALD, but many screening programs result in false positive results. And it also broadens the clinical spectrum. So you identify individuals who probably never would have ended up in the clinic. So very mild forms of the disease. Or late onset. And there's also, we've heard it already, George mentioned it, VUSs, variants of uncertain significance. And these are variants, genetic variants, for which we do not know if they are disease-causing or they are benign. And there's also uncertainty when the test results falls between the normal level and the disease level. And that is what we call the gray zone. So the challenge in population screening is to maximize the benefits and minimize the harms of screening. And in order to do that, in a perfect situation, the quality of the program should be measured and it should be monitored continuously and to improve the screening, to come closer to the target disease population. So minimizing false positives and maximizing identification of true patients who benefit from the program. So I'd like to spend a few slides on this concept. Because what I've often heard is that people say, I'm elevated. My levels are elevated. And this, it's true, but the question is, how elevated are you? Where are you on the scale from between healthy and disease? So a screen positive result means that the biomarker, in ALD, it's called the C20 lyso-PC, exceeds the screening cutoff. That means that it's outside the normal range, here shown in the green at the bottom. But the screen positive result does not automatically mean risk for disease. So there is follow-up testing is needed to determine if the biomarker level falls in the disease range and to confirm the risk for disease. And so what we see often is that there are results, they're elevated, as shown here on the images here. But if you have no insight where the disease range starts, you have you miss information. So if this is the level, if the disease range is over here, then this may not cause disease. In this case, if it's in the disease range, it's likely a pathogenic variant. And we need this information. Because in the perfect situation, screening does not exist. Because in the perfect situation, there is no gray zone. So either the level is in the normal range, or it's elevated, and then it's automatically in the disease range. That does not happen for any disease. There always is a region where there's uncertainty. So this is more a realistic situation. So population screening identifies individuals with screen-positive results where biomarker levels exceed the normal range, but may not yet be in the disease range. If you then, by definition, if it's a screen-positive, you will do genetic testing. And it's very likely that you find a variant in the gene that causes the biomarker level to be higher, outside the normal range. Because this variant may affect the activity of the enzyme, which causes then the elevation of the biomarker. However, the question is, does this elevated level fall in the disease range? And does it confirm a disease-causing mutation or condition? And additionally, the result may show variants of uncertain significance. We've heard a lot about it. And in this case, the impact of the variant is completely unclear. And this is an outcome that many families have received. And it says, this is a genetic report. And the conclusion is that a variant of uncertain significance has been identified in the ABCD1 gene. Now what? And so this is what the Gray Zone, the project started, to get insight into this confusing situation. Because all boys that come out of newborn screening with a pathogenic variant, a likely pathogenic variant, or a variant of certain significance undergo the follow-up program, which is pretty intense, with serial MRIs after the age of 2 years, every 6 months, testing for adrenal function. And it does matter if this is necessary, if it's not necessary. This is not something that you want to do to somebody who turns out not to be a patient. So ideally, here we have newborn screening. So if a pathogenic variant is identified, or a C26 lyso-PC level, which is really high, it is in the disease range, it's clear. Then we have a boy with ALD. And then, of course, follow screening with MRI and adrenal function testing is completely necessary to see whether the disease is starting. However, in this case, and this is there are many of these cases, if there's a VUS, it can still be a benign variant, and then there's no ALD. So should these boys also go in the MRI and have the function tested? I don't think so, because these are false positives. So in the ALD situation, you will find all these false positives, you measure the levels of the biomarker, and you adjust your cutoffs. That's what Sherman Gray was talking about. So you continuously monitor and adjust. So that the levels of the cutoff levels in screening come closer to the disease range. And people may think, why didn't it start like that? That's a good thought. But think that you want to set up a screening for a disease, and you have a biomarker for that disease. Where is the disease range? So what you typically do, you take 100, 1,000, 10,000, 100,000 random samples, and you measure the level of the biomarker. And you get this nice curve, and they say, oh, here's the top of the curve. So that's my cutoff, and everything that's above it is screen positive. And that's the situation where you will find variants that cause the biomarker to be above the cutoff. But does it cause disease? We don't know. So a VUS is also result in a very unclear situation. So the start of the Great Jump project is to find if a VUS is an ALD variant or is it no ALD variant. And so this started in 2017, and first we started with a test in skin cells, which was very costly, and it's very difficult to do because you need a skin biopsy, you need a lab that can culture fibroblasts from this biopsy, and then we realized, well, and also in the test we found values that were in the gray zone, so this was not really helping at all, and then. 5 years ago, together with Jorik Jaspers and the team in Amsterdam, our diagnostic lab, so not the research lab, but the diagnostic lab, that had been performing diagnosis for paroxysmal diseases since the 80s. And they've been doing very long chain fatty acids, plasma very long chain fatty acids analysis, which is tedious, it's time consuming, and it is also costly. So the lab wanted to see whether the C26 lyso-PC, which was already in use for newborn screening, why would we not use this biomarker also for confirmation of patients that visit the clinic? Why would you use a different biomarker for a newborn or for an adult? So we tested this, and we demonstrated that C26 lyso-PC is in plasma, or in dry blood spots, and in plasma is really giving you a straight line. So the levels that you find in plasma and in dry blood spots are very comparable. And why is this important? Because when we stopped using fibroblasts, we went to plasma. And also for plasma, you need to, when you do that for people around the world who do not live in the Netherlands, you need to send this plasma to Amsterdam. And you need to send it on dry ice, because if you send it at room temperature, it goes bad and you cannot do anything with it anymore. So it's also costly. If you send something on dry ice, it's costly. And also, after COVID, it turned out that some of these companies who sent stuff on dry ice were not able to get it in Amsterdam in time. So sometimes we received a sample 2 months after it was sent. Well, you cannot do anything anymore then. And so the nice thing about this is that now we can do this in blood spots. And blood spots is, of course, beautiful because you can take a blood sample, put it on a newborn screening card, and then send it by regular mail or by FedEx mail at room temperature. And even if it takes like a month to arrive in Amsterdam, it's still okay. So this really changed the project. And it's shown on this slide. And of course, we have to acknowledge Kelly, because Kelly made this all work for families. So what we can now offer is that when a family or a physician with a family and an unclear result approaches us, Kelly sends them a package for which the doctor, or even at home, from a finger prick, a blood spot can be generated. The family receives also a FedEx label that is pre-labeled for Amsterdam, and on the label it has a code. And this code is important because if the package arrives in Amsterdam, the code is scanned, and the people at our institute, we were 17,000 people, so you can send it to me, but not everybody knows me in Amsterdam. So with this code, it goes automatically to the lab, and the lab knows exactly what to do. I don't have to tell the lab, oh, this is a gray zone sample, you have to analyze C20 lyso-PC. Under that code, all the directions are already made. And in Amsterdam, we measure C20 lyso-PC, and we can compare that to the results that the lab has been generated for the last 8 years. And to show you, we've received samples from well, many countries in the world. And since we moved to dry blood spots, it really increased the number of samples that we've analyzed. We've now done more than 100. And this morning, another sample arrived. I just received an email. And we have analyzed a total of 65 unique variants of VUSs. So when these samples arrive in Amsterdam, they go to our diagnostic lab. The diagnostic lab measures C20 lyso-PC, and we've done it for 109 individuals with a VUS, and the levels are compared to the results, the growing results. So currently we have 1,600 controls, but this is growing every day because the diagnostic lab does this test not only for ALD, but also for other conditions every day on a daily basis. So we have a growing number of controls. So we have a really well-established normal level. And also we have samples from over 200 well-characterized ALD patients. So these are patients that have symptoms. So we know that these levels, the levels that you find in these patients are in the disease range. From these 109 individuals, we reclassified 49 individuals having no ALD. So the VUS was a false positive. So in the perfect situation, you report it back, and then the state or the country that did it goes back and see, hey, if you collect all these false positives, you can adjust your cutoff. Unfortunately, that's not happening. In some states, it will happen, and in the Netherlands, it does, because we have adjusted our cutoff already to minimize the number of VUSs. So 49 individuals do not have ALD, they have a false positive result, and 60 individuals we could confirm that the VUS was pathogenic. So disease causing true positives. So that's the gray zone 1.0. And then, of course, we reported it back, and then some of my colleagues around the world, clinicians, said, okay, can we do more? Because now I have the patient in the clinic, but not all patients need to be monitored the same way. So if we can predict that this individual will not develop true ALD or adrenal dysfunction, we can maybe in the future adjust the monitoring. Because here again, so this is ALD, so we can screen it at birth, but we cannot predict the outcome of an individual. So males are at risk of developing adrenal disease, which can already start in the first year of life. They're at risk of developing leukodystrophy. And in adulthood, males and females develop spinal cord disease. But there's only treatment for the adrenal disease and for the leukodystrophy. So this is the target condition for newborn screening. These are the males that the individuals that we like to identify because they benefit from monitoring. Last year, Jorik Jaspers showed the data from a publication that a study that we did last year, and this is a slide to summarize a part of that large study. But because what the study shows is that the C20 lyso-PC levels do correlate with disease severity. And it's shown here on this slide because here again we have the spinal cord disease, the leukodystrophy, and the adrenal disease. And these graphs show comparison between males that are over the age of 55 years, do not have a leukodystrophy, and do not have adrenal disease. And many studies, natural history studies, have shown that males that are over the age of 55 years, the chance of getting a leukodystrophy or adrenal disease is very low. So this is, let's say, the end of the spectrum on one hand, and the other side of the spectrum, the severe side, are males that have developed leukodystrophy. So if we compare these two groups, we see a clear separation, well, not a separation, but a clear correlation between the C26 lyso-PC levels and the leukodystrophy or the spinal cord variant. And this is also true, well, yeah, for the adrenal disease. So if we again compare the adults over the age of 55 years without adrenal insufficiency to older males that have adrenal insufficiency, we also see this correlation between the levels of C26 lyso-PC and the development of adrenal disease. Okay, and what is really important is that, well, this year, two studies were published, one from Minnesota and one from the group in Italy, because the region of Lombardia, Milano, they've started newborn screening several years ago, and Minnesota started, Troy, in 2016, 17? Yeah. And the beauty of these two regions is that there is monitoring of the individuals that come from newborn screening. Because in the perfect world, all newborns coming out of newborn screening would be followed up and monitored. And we would report all the data back to see well, again, what Silber Gray said, that we can monitor the effect of screening. So Minnesota and Italy reported data. And these are the data from Minnesota. Minnesota identified individuals with a FUS, they're over here. Individuals with a pathogenic variant, they're over here in this group. And then they monitored who developed symptoms in the first 5 years of life. And these are the boys that have developed either adrenal dysfunction or cerebral LD before the age of 5 years. And you can clearly see that these are in the upper range. And this was confirmed by the study in Italy. So here again in Italy, these are the pathogenic variants and the affected individual, and also the boys that developed adrenal dysfunction before the age of 4 years, they have 4-year follow-up, again are in the highest range. And I've been asking Mark Engelen to get the data from our boys that were picked up in the pilot and now also in the nationwide screening. And this is unpublished data from the Dutch cohort. We have also identified 2 VUSs, which we're still working on, and pathogenic variants. And also in the Netherlands, 3 boys have developed adrenal function before the age of 4 years. And also here, they are in the high range of the disease. So C20 lyso-PC levels are associated with risk of developing pediatric disease. One important note is that the levels that I report here are the C20 lyso-PC levels at screening. So these are higher than when we do the Gray Zone project, because in the first, at birth, the red blood cell count is higher, and it reduces in the first three months of life. And the C20 lyso-PC is sitting in red blood cells. It's sitting everywhere, but it's also sitting in red blood cells. So if the red blood cell count decreases in the first 3 months of life, the C20 lyso-PC also goes lower. So these values here are higher than the one I showed on the previous slide. So I think that with this data from the Gray Zone project, from our research in Amsterdam, and also the very important follow-up studies in Minnesota and in Italy and in the Netherlands of the boys coming out of newborn screening, we really can move forward because we have newborn screening. Well, again, if it's a pathogenic variant, it's clear the boy has to be monitored the way that it was published, the international recommendations. In that case, we have a true positive. In the case it's a FUS, it still can be a false positive. If we can determine if it's a pathogenic, then the boy follows the same follow-up protocol as the pathogenic variants. And I know that talking with the doctors, I mean, this is the ideal situation, that boys that have a pathogenic variant, but are at a lower risk, so the levels are lower. I mean, it's too early to do that now, of course, but this is, I think, what we should go to, is that you can alter the clinical monitoring. So how can you participate in the Gray Zone? I realize that it's always good to say that, because I've never told it, really. So if the genetic result is a FUS or otherwise unclear, we don't have really strict triage. Do contact Kelly or me. Then well, either you can do it already at the clinic, but if not, you will receive a package to make a blood spot. This part is not covered by the grant, so we are not going to pay hospitals in the United States or anywhere else to draw blood. The dry blood spot can be shipped to Amsterdam. That's covered by the grant. So the FedEx label that's automatically sent to Amsterdam. And then this is also covered by the grant. The diagnostic testing, so not the research testing, but the diagnostic testing of the C20 APC, done in the Laboratory of Genetic Metabolic Diseases. And then, well, the lab has been using this in 2019. We completely moved away from plasma varying chain fatty acids to C20 APC. And the results we will compare with the controls and the results in LD patients. These are email addresses to contact us. And oh yeah, and there's another thing. Every once in a while, we do receive a blood spot that my colleagues in the lab say, well, Stephan, you have to contact the family because this is not a good blood spot. So there are some examples. This is the perfect situation, but this is not what we need for the Gray Zone. We only need one blood spot. That's enough. Sometimes they can be smaller, but if we can make a correct punch out of this, it is still okay. But it needs to be true and true. So this is the front and this is the back. So this is what it should look like, and not like this. So here there is blood on the blood spot card, but there's not enough. So you can see if you turn it around, there's not enough blood. So that means that because if you take a punch here, we know that it's 10 microliter of blood. In this case, it is less than 10 microliters. So if you measure the C20 APC, it's not a true result. So we need a good blood spot, and this is done by Kelly at home. This is a perfect situation. This is all we need. We don't need 5 blood spots, we only need 1, but it has to be true and true. So if we receive a blood spot like that, we can do the analysis, and we can give you a result of the outcome. I think that was my last slide. So yeah, I think we are slowly leaving the Gray Zone, and we are approaching a situation in which we hopefully can predict the future for all these newborns. And so we come closer to the target disease, yeah, so then we really benefit the patients, and we do not create patients, because that is not the role of population screening, creation patients. So thank you.
See, plenty of questions here. I'm closest right here to Josh. Let me let you.
Hey, Stephan. So that's super work, really impressive. I had a favor and then a logical conundrum. So the favor is, I think with the data, one concern, kind of as we think about looking at this and trying to roll it across kind of at a population level, will be to make sure that's true regardless of like patient background. And so collecting racial and ethnic information on patients, I think will be really important to have kind of generalizability. So just as you do this, try to collect that data somehow. So it's the favor. And then the logical conundrum, so it's kind of like back in middle school when you're taking geometry and those questions like if A plus B equals C. So the conundrum is, so I see in the 2024 data that you're presenting that yes, the higher C26 lyso-PC levels are seen in patients who develop disease phenotypes. So therefore, yes, there's higher lyso C26 levels. But I think the converse doesn't seem to be true. So lower C26 levels doesn't mean that that you're safe because you see that in your disease cohort as well. So I think being careful not, or at least with the data that seems to be there, interpreting the converse doesn't seem to be true.
No, absolutely true. So the first one, yes, of course we would love to have plasma samples, dry blood spots from non-affected individuals from throughout the world, so we can, but we don't have access to that. So if you have access to samples from controls from other ethnic backgrounds, yeah, of course we would love to analyze that. Yeah, and the second point, the diagnostic result that you will receive from Amsterdam is just shows you the level. It does, if it's in the normal range, it will conclude it's not ALD because the lab does for more than 300 metabolic diseases clinical diagnostic testing. So this is standard practice. If the result is normal, it is a normal result. But the information that you will receive does not say this is low risk or high risk. It says we compare the level to the 1600 controls, and it will say, well, it's outside the ALD range, and then there will be a remark that our research shows that this is the disease range, and it's falling in the disease range. And we will not say it's in the high risk or low risk. So we will get a result that's either in the normal range, it's still in the gray zone range, or it is in the ALD range. We don't do any recommendations to anybody regarding follow-up. That's not up to us. For any diagnostic lab, that's not up to the diagnostic lab. It's up to the physician and the family. If that was your question. More or less.
Hey, Stephan. Thanks for your talk. This might be a naive question, but have you or has anyone mapped these variants of uncertain significance onto the ABCD1 structure to be able to build some sort of predictive model going forwards for, like, variants in this part of the protein, or particularly sort of like fairly, variants from amino acids to fairly synonymous amino acids are most likely to not result in, a pathogenic variant?
Yes, I received. Where's Triana? Where are you? I haven't seen her. My colleague from UK, Triana Amen, who's going to present today, she did that. She mapped all the variants. I haven't. I received it yesterday, so I need to look at it. But it's something that we do. But the question is, does it give you really information? Because it is insightful, and so for some variants it's really clear if they are in the active pockets. It's rather clear that they probably are pathogenic. But if we're sitting on the outside, we still don't know. But yeah, it's something that we're also doing in silico mapping.
Thank you, Stephan. My concern when I look at it is if we're only collecting these cards from VUSs, are we just getting a bias set? And by not continuing to check people that we think have a pathogenic mutation, because in that chart, it did look like, I think what Josh was saying, that there are dots that are crossing each other. And so if we just leave it at those 200 plus or whatever you have, I worry that because we all know families where there are pathogenic mutations, but one person for whatever reason does better or worse. And I just worry that we're biasing our sample.
Thank you for bringing this up, because I want to do a shout out here to all my colleagues throughout the world to send in samples from confirmed ALD patients. And I know there's a box waiting in Minnesota to be sent to Amsterdam, and I think you said a few hundred. I mean, the more samples from ALD patients we get, the better the data is. Because, so absolutely, so any sample, every patient that shows up in clinic, please make a blood spot and save it. And it also counts for DNA, stored DNA. Because, of course, the C20 lyso-PC is part of the puzzle, but it's not the complete answer. I think Florian mentioned modifier genes. It's another project that we will start. It's called 1,000 ALD genomes. Since the identification of the ALD gene in 1992, people have been hunting and looking for clues in other genes that precipitate on top of the ABCD1 variant and determine whether a patient develops leukodystrophy or not. We know that they are variants. They're all there. So, but nobody has ever been able to find them, and there are some reasons. In the past, it was technical reasons, cost, but also the same background that we now see that there's a correlation between disease severity and biochemistry. That's the first time that has been shown, but because all past publications do not show that. But it turned out that the samples were drawn, and they would said, okay, this is an asymptomatic individual, and there was no natural history. So some of these samples, they were mislabeled. And in this study, Mark Engelen, he has the Dutch ALD cohort, and we participated with Minnesota and with Leipzig. So we now have had a set of samples from well-characterized ALD patients. So we know if they have a leukodystrophy or adrenoleukodystrophy or when they reach the age of 55. And if you do that, you will find the correlation with the biochemistry. And this is also the sample set that we want to have for the whole genome sequencing. Because I mean, it must be the way to find the modified genes if they're out there. Oh yeah, so your question. So please set up a biobank, store blood samples, store plasma samples, store blood spots, and DNA, because this is what we need to move on. Talking about move on.
We've got several more questions for you, Stephan. We might not have.
Yeah, I need to
full
cut
time
down my
before the break.
answers.
Maybe just keep the answers real
Yeah,
short,
I will.
okay?
I was just curious, when you were saying that the C26 levels fell after 3 months, are you trying to get newborn for diagnostic testing, or does it matter?
No, yeah, that's a good point. So we enroll samples from boys that are past the age of 3 months, preferably 4 or 5 months, because then we know the levels are stable. There's also a question that was asked: how do these levels fluctuate? So Inge Dijkstra, my technician, she analyzed blood spots from ALD patients that were more than 4 years apart, and she measured the lyso-PC levels from, and in 33 of the 36 patients, it was a straight line. So these levels do not really change anymore.
Oh, thanks for the speech. Maybe you already answered to my question with these, but I was wondering if these biomarker can be used or is being used also for monitoring the evolution of the disease also after the treatment is administered, whatever the treatment is.
That's another excellent point. Yes, we published a paper in 2015 that following bone marrow transplant, the variant did not drop. It was criticized, and so we did it again together with Troy. Troy had samples from boys that received transplant, and he had blood samples pre-transplant, and then 6, 12, and 18 months post-transplant. We measured C20 lyso-PC following transplant, and we saw a reduction in the C20 lyso-PC. And in some cases, they were approaching normal levels, but they all went down. So yeah, you can monitor C20 lyso-PC if your treatment addresses the biochemical problem. Absolutely.